of the Lean Global Connection called Better Care, Connecting Metrics with Decisions. My name's Nicole Amsing. I work with Lean Enterprise Australia in Australia, and I'm one of the coaches there. And I'm thrilled today to be joined by Sarah Arana. Sarah is an improver from way back, and also a fabulous nursing leader. And she works at the Royal Melbourne Hospital in Victoria in Australia, one of the largest hospitals in that state. And Sarah is the Director of Access and Patient Flow, and is also the Acting Director of Nursing and Operations in Access, Critical Care and Investigative Services. And the focus of our session today with Sarah is really looking at the novel way in which the Royal Melbourne Hospital is connecting metrics with their daily decisions to think about how they support their operations and deliver quality and safe care to all of their patients and support their workforce every day. So I'm thrilled to have you with us today, Sarah. How are you?
Thanks, Nicole. It's great to be here. Thanks so much.
Fantastic. So as I said, Sarah has a leadership role at the Royal Melbourne Hospital and leads the Digital Coordination Centre. Sarah, can you tell us a little bit about the Royal Melbourne Hospital and the Digital Coordination Centre?
Yeah, sure can, Nicole. So Royal Melbourne, or as we call ourselves, RMH, is a large trauma and specialist hospital in Victoria. We've got about 600 beds. That ebbs and flows as our demand needs it to. But we really provide a lot of services: neurosurgery, trauma care, transplantation, cardiology. Really big centre. We are based right in the heart of Victoria. So we're really in the centre of it all, one of the two trauma centres for the state of Victoria, and lots of specialist nursing, medical, allied health and support staff that really help us deliver our services. In terms of the DCC, this is our Digital Coordination Centre is a really new thing here at Royal Melbourne. We only were established back on the 28th of August in 2023, and I was really fortunate enough to join Royal Melbourne to help us operationalise this. And this centre is really a part of our vision at Royal Melbourne to be a digital health service and to use our real-time data and metrics to help inform our clinical operations. So we've got we spent 10 months on the project in designing our coordination centre, really purpose-built. We went and learned. So we went to places across Australia and internationally. Some of the team travelled as well to learn about what was happening overseas and also out of other industries. So not just healthcare. It was really important that we went and learned around how command and coordination centres worked in other industry as well. And we brought that all back to design a space and with the right people in it to deliver a coordination service with our real aim as we're here to help, we're here to collaborate with the rest of the hospital if there's a problem. So our first focus in our DCC has really been around access and flow for patients. Coming out of COVID, we were really struggling to get our patients timely care, both patients coming through our emergency department and patients on our elective or planned surgery waiting list. So this was really designed in the first point to really tackle that problem of how do we improve access and flow. So it's a combination of using our metrics and the team we have in the DCC working together. One without the other wasn't going to work. It was important to get the right mix of the two.
Yeah, fantastic. And what Sarah's done for us today, everyone, is we've pulled together some videos so we can actually see some things in real time. So in a minute, Sarah's going to share a little bit of a day in a life of one of the important team members from within the DCC, Sam, and then we're also going to get an opportunity to listen to one of the huddles that actually happens in the DCC that, or across the organisation actually, with support of the DCC that Sarah has videoed for us and that the Royal Melbourne has agreed to share with us. So we're very privileged to be able to kind of get a really up close and personal look at how the real work happens, Sarah. So that's terrific. One of the things for us to perhaps come back to talk about afterwards, so I'll give you a bit of thinking time while we're sharing some videos, is, what did you learn from other places that helped you setting up? So something to to think about while we're looking at some of these videos. So Sarah, I'm going to ask you now if you can share your kind of day in the life of, and then once you've done that, we'll come back.
Come with me on a typical day at our Digital Coordination Centre. We use information from across the hospital to focus on getting patients the care they need when they need it. Every day starts with a huddle to see how many patients we have, how many are projected to be discharged, and how many we predict will be coming in. If there's a problem, we're all here in the DCC, ready to help solve it. We aim to remove any barriers for a patient waiting to be discharged home or to their next destination. We work with doctors to get scripts ready or to review test results. We check how many surgeries we have planned and what theatres we need to support emergency surgery. And we make sure we have the right teams in place for patient care. New patients are arriving all the time, so we are constantly reviewing our bed capacity across the day. That also means escalating maintenance requests and bed cleans, so we're always ready for the next patient. In the afternoon, we meet to get ready for tomorrow by looking at what patients need to help get them home. At the end of the day, we hand over to the night team and get ready to do it all again tomorrow.
Fantastic. Thanks, Sarah. And it's a great little clip there at the end of a Melbourne tram. So absolutely seeing the real life kind of local Melbourne and Royal Melbourne experience. So one of the things that Sam talked quite a bit about there in the presentation was about huddles, the way you're looking at things all during the day, thinking about how your organisation changes across a day and how that might impact the things that you do, the things that you need to decide. Can you talk to us a little bit about the daily rhythm of the DCC and how it kind of all hangs together?
Yeah, absolutely. So the daily rhythm is most of our staff, whilst our DCC is manned 24 hours a day, most of the team come in at 8. So a lot of the team don't report all in together. We're from lots of different teams and work in the space together. But really, once we first arrive, our job is to look at the data for the day. And each person has got an area they're responsible for to identify, are there problems? Are there hotspots? We like to call them hotspots across the hospital where we think we're going to have challenges that might be around not enough discharges, too many planned admissions. It might be that we've got a broken light somewhere and the bed's closed. So we are all having that deep dive into our own areas, and then we come together. And when we're deep diving, we're looking at dashboards. So we've got lots of purpose-built in-house dashboards using our electronic medical record. And the really important thing about these dashboards is that they've been built with the purpose of taking action. So you're not going to see a run chart. You're not going to see anything that's about yesterday. It's about what is happening right now in this moment. And that is really what helps us to go, there's where the problem is, there's where an issue is or an opportunity is, where we can take some action to make things better. So that's sort of that first part of the day. And then at 8:30, we all huddle together in the DCC. Sam, who you just saw in that video, he's our manager in access. He often leads the huddle, though we do rotate it a bit as well. And the team come together to, I guess, talk about what they've learned in looking at the data for that morning. Where are those potential issues, and what do we think we need to do either in the DCC or as a health service in other areas of the operations to really move patients to the right place and make sure we're in a green state. We also look at what we call escalation triggers. So they're inbuilt to one of our dashboards, which you'll see in the huddle when we show you one of the huddles shortly. And those triggers have been built to really tell us as a whole organisation, are we green and good to go today? Are we red or are we amber? And depending on whether we're green, red or amber, there's different actions that we will take and different thresholds met. You know, we don't like being in the red. We've only been in the red 4 times since we went live. Our aim is to stay in the green. And if we end up in the amber, it's all about what action can we take now to prevent deterioration and get us back to that green zone. Because we know we have a safer and calmer hospital, which is better for our patients and staff when we're in the green. So that's really what our huddle in the DCC is really about, identifying what we think we are for the day. As I said, those hotspots, those actions we've already taken or we want to recommend are taken across the organisation today. And so it feeds into the next huddle, which is the organisation-wide huddle, which you'll see shortly. Yeah.
Fantastic. And so, Sarah, One of the things I think that's worth drawing out there is you talked about the fact that you do your huddle, and I imagine you're doing problem solving and trying to work out actually what's within your kind of sphere of control, sphere of influence, sphere of facilitation, really, in terms of your engagement with the organisation to solve problems, to try and get you from, as you say, from amber to green, or to stay in the green. And then there'll be some things that actually might not be able to be resolved that way, and then you're escalating them to a tier 2 huddle you talked about.
Yeah, correct.
So we're going to have a look at a video of the tier 2 huddle in a minute. But before we do that, Sarah, can you talk a little bit about who's there, who leads it, what's its purpose? So we've got some context before we switch it on.
Yeah, absolutely. So the Tier 2 huddle is a pretty open invite. It's our main organisation-wide huddle that's held every day. It's attended by our executive, by all of our service operational and support leadership teams, our nurse unit managers and heads of unit. In terms of the purpose of the huddle, it's really so that everyone understands where we're at today. Are we green, amber, or red? Where are the problems and what are we doing about them? And who needs help? So it's that opportunity, as you said, to escalate, has the right people there to help solve the problems. Sometimes when we find really big problems or really big challenges, there'll be a smaller group that stay on at the end of the huddle. So you've got those right people together again to go deeper and go, okay, this specific problem, how are we going to work through it? So the DCC facilitates that huddle. So you'll see Sam facilitating. So we take what comes out of our coordination centre and we help facilitate it and give an overview. We run through our daily huddle dashboard so people can see the data. All of our staff who have access to our electronic medical record can access that dashboard at any time, and we use it. It's really important to us. We trust it. Everyone trusts in the data. Everyone understands how we use it. So it's been really valuable. And then each service or support service will come to that huddle to also identify whether they're as their own department, green, amber, or red. Do they need any help, or what actions are they taking to support their service today? It's a pretty quick huddle for one that's attended by 80 people. It's all over in about 5 to 7 minutes, depending on the day. So it's really, people are very tight on, rather than telling the story, it's around what's happening now, what's our action, what do we need to do?
Fantastic. And so, you talked about the fact that you'll have your huddle, then Sam will facilitate that organisation-wide huddle. So are other people that are coming to that huddle, have they been huddling with their kind of local tiers as well, their local teams?
Yeah, absolutely. So you'll hear me talk in the huddle because I'm in that acting director of nursing role. So I've been out and seen my teams, understood what's going on and where their problems are or their pain points are for the day. And so that's happening. Each service does that a little bit differently, but absolutely that happens right across the organisation because it really feeds into that org-wide huddle. So we know really early in the day where we're positioned and what we need to work on to make it a good day.
Fantastic. Great, Sarah. So let's take an opportunity now to actually have a look at that video. I've got it here with me, so I'm going to screen share that with everybody now. So let's have a listen to that.
All right, good morning. Welcome to Thursday's Tier 2 as we meet to identify any actions to support our operations. I'll hand straight to Karen as exec on call, please, Karen.
Morning, Sam. Thank you for that. In the out-of-hours space, nothing really to escalate. There was a little bit of demand for cardiology yesterday evening, but I believe everything else was manageable. From looking at the last 24 hours, there was 250 presentations to ED, 82 via AV with a 77% offload, which was a very impressive improvement on the day before. We predicted 87 discharges at 9 a.m. yesterday, and we achieved a whopping 110. So great work by everybody. There was a 20% of our patients went via transit lounge, and the discharges by 10 o'clock were 14.5, which was down on the day before. Our overall need was 63%, which was up on the day prior, and similarly, our ward needed also improved at 36%. Thanks, Sam.
Thanks, Karen. Yeah, big day yesterday. Nothing open on our action log, so we'll have a look at the day ahead. Another really great start to the day, recommending green this morning. We started the day with some empty beds, 89 projected discharges for the day, but a great 25 of those already confirmed. We have just about everything allocated in ED. Just noting there's still quite high mental health demand down there. ICU also a little bit tight this morning. However, we'll be able to prioritise getting any ward-ready patients out as they come up. From nursing workforce, all general areas okay this morning. Just ICU with 4 unfilled vacancies and theatre with 3. For the PM, there's good staff available, and just noting ICU as a hotspot with 3 vacancies at the moment, and for night duty looking pretty good with staff available as well. There's also been an issue noted this morning with CAFM single sign-on, which is being looked at by Digital Innovation at the moment. And there is going to be some communications that come out regarding that. And that's it. I'll go to medical services, please.
Yeah, thanks, Sam. Medical services are green and ready for the day. Probably 2 areas where we're predicting to have lots of capacity, and we'd like to review, I guess, staffing and beds this afternoon. So that's 5 Southwest and 8B, and we'll work with the DCC to do that. Thank you.
Great, thanks. Christy, surgical services.
Yeah, good morning, Sam. Again, we are green overall, recognising 7 Southwest does have 5 electives today, but they've already got 2 confirmed, another 4 queries, so we think we'll be able to hit our target there. Thanks.
Karen, can I just ask about, I just noticed that ETBS was sort of high this morning. Is that right, that figure?
Yeah, so we've actually got a bit more capacity. Some of the elective work is going to be shorter. Yeah.
Thanks.
Yeah.
Thank you. Home first.
Thanks, Sam. We're green and ready to go. No major issues.
Thanks, Melissa. Mental health.
Morning. Thanks, Sam. Mental health services have 13 people on the track board. We've got 6 people ready to go from ED, with 5 of those are ICA. So the demand's really sitting in the ICA space. There's a -3 bed variance for ICA today. We'll be able to get 2 patients up this morning. There's good GCA access, and hopefully as the day goes on, we'll be able to translate that and equalise that out. But otherwise, good to go. Thank you.
Thanks, Fiona. ACCIS.
Thanks, Sam. Look, we're green and good to go. We've just reached out to security. We do have some high OVA potential in the ICU today, so we'll reach out to the OVA team about that as well. Thank you.
Thanks, Sarah. Allied Health.
Hi there, we're green and good to go today.
Thanks, Leonie. Pharmacy.
Morning, Sam. We're green and good to go. A little bit short on our heme for the acute leaks and the specialty involved there, so we're just spreading around a little bit and maybe tiny bits of delay there, but we don't expect anything significant. Script-wise, good start to the day, 38%. Thanks.
Thanks, Dan. Pathology.
Morning, everyone. Pathology's green, nothing to escalate.
Thanks, Simone. Medical imaging.
Morning, Sam. Unfortunately, very red today. We've got 14 radiographers off and 3 late calls. So we've pulled everybody on the floor. We've moved a number of outpatients across MRI and ultrasound to meet our inpatient demand. But please escalate to the duty reg or myself or Di Pasco, and we'll prioritise those patients. Thanks very much.
Okay, thanks, Luke. Security.
Yeah, good morning. We're green and good to go. Thank you.
Thanks, John. OVA.
Good morning, Sam. OVA is green for staffing, and we'd be very happy to come and support ICU in the 7th floor with those transitions.
Thanks, Abby. First Nations Health Unit.
Morning, everyone. We're green and ready to go with nothing to escalate. Have a good day.
Thanks, Lani. Medical workforce.
Thanks, Sam. Operationally green and ready to go. We do have some vacancies this morning. I popped them in the chat, and we're just working through our escalation procedures for those. Thank you.
Thanks, Lauren. IPS.
Good morning. We're green and ready to go. We're monitoring 65 patients, 47 in isolation. We officially have a norovirus outbreak in 5 Southwest with the 2nd patient testing positive for norovirus. The original index has been discharged, but it generated 2 contacts.
Thanks, Karen. Supply.
Good morning, everyone. Supplies green, nothing to escalate. Thanks.
Thanks, Pauline. EMR?
Hi, Sam. EMR's green and good to go. Thank you.
Great, thanks, Adam. Digital innovation?
Good morning, everyone. Our team is working on the single sign-on issue, which is impacting access to the CAPAM application. Updates will be provided via email and workplace. Thank you, Sam.
Thanks, Cecilia. And quality?
Morning, Sam. We're green and ready for the day. No new serious incidents in the last 24 hours. Nothing further to escalate.
Thanks, Sean. Jackie?
Yeah, good morning, everybody. Happy Halloween for those. I've seen some little kids dressed up this morning, which is gorgeous. I don't have any chocolates for them tonight, but anyway, that's my issue. Okay, we're green and good to go. Medical Services, can I just check in that you're all good with the norovirus? No actions, nothing that you need? Christy?
No, we're good.
Yep.
I'll follow up with Ips. We've been catching up with them each day, just
Okay.
with a plan. So yeah, nothing to escalate, Jackie.
Thank you. All right. And so our only area with a spot of bother today is imaging. So escalate early if there's any issues for there. So thank you, everybody. Have a lovely day.
That's fantastic, Sarah. I found myself thinking about your day, knowing that that was recorded, a week or so, a couple of weeks or so ago. I'm thinking, what kind of day are they having? I had to keep reminding myself that actually I wasn't in the thick of it. So it was terrific to see the team, and a couple of things that stood out to me that I would probably want to draw out and share with the people that are listening is that Sam started off being really clear about the purpose. We're here to around operations and to take action. And so the other thing that you heard was how that purpose really turns up in everybody's report. So it's not a tell my story of the day. It's if I need a hand with anything or if I've got a problem, I'm letting you know. And also, if I've had some problems, I've resolved them, or this is what we're going to do during the day. So, that is one of the things that that really stood out for me. And the other thing that I thought was fantastic, two things. The overnight person starts off talking about a little bit of reflection, how we went yesterday, and how does that compare with kind of our usual performance the day before? We're getting better or worse. And the other thing that I thought was really impressive and worth drawing out, having seen a lot of these kind of things in a lot of different organisations and industries, is that people are using data. So they're saying the numbers. It's this many of this, it's this many of that. It's not, oh, we had a quiet day, we had a busy day, we had a good day, we had a bad day. So people are really using those metrics to inform their practice. Sarah, can you talk to us a little bit about how you got from not having this thing to actually getting to that space, and a little bit about the development process and the kind of capabilities and behaviours that help support it?
Are you talking from the huddle perspective or
Yep. Or both, really.
Yeah,
I mean, I think it's about an integrated system,
it's an
really,
integrated
isn't it?
system, yeah. I think the first, in the lead up to the DCC going live, I think a lot of work was done around data and making sure that, you often hear in health services, people go, well, the data's wrong, right? Well, we can't trust the data. So I think, having a culture where we use estimated discharge date and that's used really well. So that is one of the key data points that feeds into that daily huddle dashboard that really helps us. So we trust it. We know if it says we're going to have 85 discharges today, we're going to have somewhere between sort of 80 and 88 or 90. It's going to be pretty close. So I think, and helping, when we went live, we had a lot of clinical teams come and see the DCC.
Yeah.
We had open hours where teams could come in and learn about how the team in there was using the data. And so it was almost those penny drop moments for people to go, oh, okay, that's why that's important. Okay, I get that now. And so I think that's only strengthened understanding why the data is important. And we used to have huddles that were based on feelings, right?
Yes.
We feel like we're red, we feel like we're amber. So, it took a long time and a lot of work by a really senior team and with exec support to develop the escalation triggers so that people were, okay, this is as an organisation. And now you'll hear people, each service says whether they're green, amber or red, because they've been building their own internal escalation triggers of what that means for them as a service. So I think that's been really important. And then there was a lot of discussion with people around reframing the purpose of the huddle. So the huddle used to be facilitated by the executive on call, whoever had been on call, and it was very different depending on who that person was, because it wasn't sort of set in. So there was a lot of meeting with people saying, this is what we're trying to get out of it. How would this sound? And some coaching around how to be more action focused and how we're going to bring that. And so, I wish we'd recorded one when we went live. And now we look at the one now, because I think you would have seen over time that we've become slicker and slicker at it. And it improves more and more as we learn. And then a couple of days a week, we do things like Wellbeing Wednesday. So we have someone come and do a couple of minutes on something going on, or we reflect on our values and share stories on Fridays that link into our organisational values. So, yeah.
Fantastic. That's great, Sarah. So one of the things you talked about then is you wish you had have done a kind of recording of one of your first huddles and to see how you've progressed. Can you talk to us a little bit more generally about the impact the DCC has had on the Royal Melbourne Hospital, the way it operates, and the staff?
Yeah. So I think when we went live, we were often in red. The hospital was red, and we just need more discharges. And we predicted based on where we'd set our triggers that we would go into red maybe once or twice a month. And in reality, it's only happened 4 times in sort of 16 months now. And we think that's probably, again, because we're using the data to be more proactive. We can see the deterioration happening in the system, so we take action earlier. So I think that's been really important.
Yeah. And so, the other thing I know, because I've been to visit and have heard these stories before, that if you think about your performance over time, you've also seen some reductions in some of your kind of performance.
It's been pretty incredible. And look, we've had a lot of range of access and flow projects happening across the hospital. We did a whole change to our bed plan and lots of different things. But since go live, we've seen our length of stay in the ED dramatically reduce. We've seen the time that patients take to get from the ED to a ward really shorten. Sometimes we're meeting performance targets that are set by the government that we thought we would never meet in our wildest dreams. And our occupancy has dropped. So we have more beds available. We're able to admit to our wards 24/7. We don't come on in the morning to a full ED of patients waiting for a bed in the hospital. We haven't cancelled any elective surgery based on access. So these are incredible things coming out of COVID, and has meant that we've been able to deliver a lot more care in the last 12 months than what we had previously.
Yeah, that's fantastic. And I mean, we haven't got a lot of time today. It's only half an hour and there's a really large story here to tell. But, I know you've got a series of run charts that show that beautifully, and you can see some of the step change. And as you say, I think, the DCC has been part of it, but it's not been the only thing. There's been a range of other things that are going on, and there's been this kind of coordinated, I think, an integrated way of thinking about your patient flow and how you support your teams to do their problem solving. That's kind of part of the secret sauce, I imagine. Sarah, we've only got kind of 1 minute or so left. So I was going to ask you a question without notice. If someone was starting this journey today, what's a couple of pieces of advice that you would give them based on what you've learned from your experience and what you learned when you went and saw some other organisations?
I think really getting people to buy into the data that you're going to use is really crucial, and making sure that that's medical, nursing and allied health staff. So that's a whole culture change and piece in itself. And I think spend the time in developing your team. What's been really important in the DCC is that we're not hierarchical. Everyone has a voice, and it's really important that we listen to everyone's voice, because the ideas can come from anywhere and they should be encouraged. So I think that's probably my other, you want to make it a really flat hierarchy, and I like to call it our team of teams in there. Lots of people from lots of teams working together.
Terrific. All right. That's great, Sarah, and really important things to keep in mind. And, you know, so much is sometimes spoken about the data. And I think one of the things that you included there in your closing comments is it's got to be about that and about the people. So, you know, if we think about this being a lean conference, that respect for people is at the heart of all that we do, and we can see it turning up in the work that you do. So can I congratulate you and the team at the Royal Melbourne on the success of your work and of your leadership of the DCC. And thank you for sharing with us today, and also for allowing us to kind of get up close and personal by viewing some of those real videos. That wasn't make-believe, that was the real thing, and being able to see that. So a trip to Gemba, really, in a videoed environment. So thanks very much for that, Sarah. And we might just leave it open now for us to see if anybody's got any questions that they'd like to raise, and pop them in the chat.